So, good morning. Jane Stirk, the leader of the Green Party. And we're meeting again to talk about healthcare. And specifically, since the budget was just tabled recently, they're talking about reducing funding for doctors. And I've heard a while ago from community clinics that they would prefer doctors on salaries. What is your opinion on reducing funding for doctors in order to save some money?
Well, there's two parts to that question. One is how do we approach the payment of doctors? And the Green Party does believe that we could make a gradual transition to salaries for some of our doctors and moving away from the fee-for-service model, which tends to allow some doctors to make extraordinary salaries and some doctors to not make a reasonable salary. So that's one of the issues that we think needs to be addressed.
So how would you address that?
Well, one of them would be to have a broadly based conversation, including the doctors, about transitioning some of our doctors to that salaried position, which would allow, for instance, say a gerontologist that has to spend a lot of time with an elderly person to be able to get a reasonable level of compensation and be able to spend that time. So the fee-for-service model tends to restrict the amount of time that you can have. In terms of whether or not we can constrain the costs of healthcare by constraining the costs of doctors' salaries, that's a much bigger question. And the budget is attempting to use strategies like that to constrain the escalation of healthcare costs to 2.6% from the normal almost 6% that we've been seeing. And I don't think that trying to target aspects of the healthcare budget without looking at the whole of the healthcare budget is a good strategy for reducing costs overall.
In the budget, they were talking about reducing funding for doctors. Would putting doctors on salary be a good way to start reducing the budget for doctors?
Well, the budget, first of all, didn't talk about reducing the budget for doctors. It talked about capping, sort of not increasing it any further.
All right.
In salary negotiations, which are coming up. And a lot of the early critics of the budget basically pointed out that the doctors are a pretty strong lobby group, and it's quite unlikely that they will accept a net zero mandate, and that similar to what the public sector workers had to face. But putting doctors on salary, or at least some doctors on salary, is definitely a way that the province should consider moving in. And in particular, for family doctors, there have been quite a few pilot projects and studies that show that having family doctors work on salary in more integrated practices with other health practitioners that are not doctors, with nurses, registered nurses, dietitians, nutritionists, and all sorts of other healthcare practitioners can reduce costs and improve quality of care for the patients.
So the question is whether the healthcare system, the medical services plan, should hire doctors directly, or whether it should pay doctors as independent contractors, but public pay. I think the reality is that we negotiate these questions and doctors don't like to call it collective bargaining, but we negotiate these questions with employees as we do negotiate in other sectors. Okay. And the agreements we've negotiated with doctors are fee-for-service agreements. So I don't think the key question in many respects, I like and I think that the shift to salaried doctors is a good idea in lots of places. I think what you have, what we have as a reality is a combination of one and two. We have salaried doctors, we have salaried health professionals, we have nonprofit hospitals, clinics, and labs. We also have an element of patient choice.
Okay.
And beyond that, we have elements of the system that aren't covered, right? So, for example, there's limited coverage for things like physiotherapy, where there's joint
that's
payments.
another question.
And those are other questions.
Yeah,
that's the scope of it. But what we have is a combination of one and two. So I think you know, I think it's not just when you're talking about the way we pay people and the way they negotiate their conditions of work, whether they're doctors or whatever. It's not just a matter of imposing something in the system. These things are always negotiated collectively, and I support that kind of negotiation. So it's not something I would impose. I would say that what we have is a combination of one and two. The key question is whether we have a publicly financed system and whether people have access to a high-quality universal standard of care, and that's what I would emphasize. If you're voting yes for number one, as the majority do here, what they're saying is that we should tear up our current contracts with doctors and push all of the doctors to be on salary. And I don't think that's what the people here are saying when they're voting for number one.
Well, they're saying salaried doctors, healthcure professionals, non-profit. That's what I hear.
But I think, and they're essentially saying that those changes should be made and imposed on doctors and health professionals.
Well, it means that.
I know.
To me, it means that.
But I don't.
But you don't think that that's what they're saying?
I don't think that's what they're saying. They're saying that that's what they prefer. We live in an open society, in an open market society, right? And that we have to have a discussion of what the consequences would be of imposing that from above.
What do you think the consequences would be?
Of ripping up our agreements with doctors and that were negotiated over decades, and say you have to be salaried doctors of the province of British Columbia?
The changes are happening all the time.
Yeah, I agree.
And I'm sure that you want some changes.
But absolutely.
But
I think we have to promote,
yeah.
And I think there's lots of circumstances where we have to promote the salaried doctors. But I'm just saying that I wouldn't agree, and I don't think most people would agree, if you said, okay, well, you're going to rip up signed agreements with doctors and impose a different solution on them. I don't think it would work very effectively, because you'd almost instantly have a strike, you know, if you wanted to do that.
Well, Tommy Douglas had that.
Yeah, but he had a strike about something more fundamental, right?
Another form of reducing costs, they were talking about reducing the cost of generic drugs.
Well, generic drugs are cheaper than the brand name pharmaceutical drugs, and I think everybody has talked about increasing the amount of generic drugs that are used in our pharmacare system. And we've also proposed that we should be exploring bulk buying so that we can again reduce the costs of pharmacare. The other part of reducing costs of pharmacare obviously are reducing the amount of drugs that are prescribed to people. And that's, again, another thing about what's happening in healthcare that we think needs to be addressed. We need to look at why we're escalating the number of people that are on pharmaceuticals, and are there other strategies that would allow people to retain their health without being prescribed drugs?
My understanding of the budget proposal is that they're not doing anything, that the BC government isn't doing anything active to reduce the price of generic drugs, that they're just relying on some patents expiring naturally. And that's what they're projecting will lead to reduced price of generic drugs. But I do think that the provincial government should work in collaboration with other provinces in Canada and actually work a lot more on negotiating drug prices collectively so that they can get lower prices instead of every province negotiating separately with the drug manufacturers. There's a lot of room on the drug front, especially around our industrial policy, or how we buy drugs and what drugs do we buy and how we negotiate the price. I think there's a lot of room in the way that we negotiate drug prices and basically set our industrial policy around drugs, drug purchasing, that can be improved and can generate savings. Province can work collaboratively with other provinces, and there have been some first steps but most of it has been just talking and no action so far. So I think this is definitely a way that the BC government should go.
Capping for-profit lab service fees. That is another possibility. And do you think that is a good idea too?
Well, I think that we need to negotiate those things. We have a privatized lab service, and at the moment we have two providers, and one of them's going to buy the other one. So we're going to be reduced down to one, which is a monopoly. And I think it's important to look at the costs of lab services, and that's a negotiation that should happen with the government so that we can say what is a reasonable cost for a particular lab service and make sure that we're containing costs within that reasonable amount.
Mm-hmm. About 41% of the money that they spend goes on healthcare. So healthcare is by far the government of BC's largest spending item. And it's the same across most provinces. I think healthcare is a great example where governments can spend here in Canada, including the BC government, less on healthcare than what they do currently, but they're not going to negatively impact the quality of services that British Columbians get, right? So the key is that as long as you're reforming the way the program is delivered, you can spend less and get good quality services. And I think that's ultimately what British Columbians want. They don't want just to cut across the board. They want to maintain their services. The only way that we're going to do that is if we reform the programs.
Mm-hmm. Do you have a practical example of what do you mean by reforming the service and making it more efficient without spending so much money?
Sure.
Just one little example.
Okay, well, for healthcare, I think if we look to other countries around the world, countries that have universal portable healthcare like we do in British Columbia, they tend to spend less as a proportion of their economy on healthcare, and they get better outcomes. So they have fewer less wait times to access critical surgeries. They have more medical technologies on a per-person basis. They have better access to doctors and nurses. So the key is, okay, what are these jurisdictions doing? These are jurisdictions like Sweden, the Netherlands, Switzerland, countries in Europe that they're doing things differently than BC. And there's several lessons, several practical lessons. One is, how do we fund hospitals in BC? I don't want to get too much into the details, but there are ways to fund hospitals that we don't do in BC that will improve the way hospitals service patients and service them more efficiently. Another example would be to look to user fees. So when people are interacting with the healthcare system, if they're not paying any amount of money out of pocket. They pay through taxes, of course, but not out of pocket. But the out-of-pocket expense, we know, serves as an incentive for people to use the healthcare system more efficiently. And these are reforms that have been used in other countries, and they've worked well to contain costs, but also to ensure that people are getting access to the services, the healthcare services they need.
Yeah, so they're saying they're putting $500 million on, they're adding to the budget, the healthcare budget.
The growth over the next year, the growth of funding over the next year is 3%, right? 3.3%. Mm-hmm. So what this means is that it just covers population growth at 1% and inflation at 2%. So there isn't actual real increase after you take account of population growing and inflation.
Mm-hmm. I've heard that as shifting the cost from tax revenue into individuals' pockets. So is that really more efficient for the individual to pay one way or the other? Because in the end, if you have to pay more for an ambulance or for private service, you're paying more. You don't pay as a tax, but you pay as user fees. So how has it helped the individual?
Well, the key is incentives, right? So how does it impact people's incentive to use healthcare? So we know that currently there are many cases that have been well documented where people are, for example, using the emergency room in hospitals to access healthcare when they need it, when they don't necessarily need it. Sorry. So if people are not paying out of pocket, so in other words, if they don't have an incentive to think about when they're using healthcare services, they'll just continue to use it because the cost of using it on the margin is zero. But if there is some sort of an incentive, a disincentive to use the system when they don't need it, in fact, that shows that people will use it less, more resources will be used to people who actually need the services, and overall the quality of healthcare won't decline. In fact, there's been several seminal studies that have looked at this in the literature, and they found that with small user fees, healthcare can improve as long as there's a mechanism in place that protects those who can't afford to pay the user fees. But in fact, we know at the end of the day, quality can go up and the efficiency can go up at the same time.
Well, I don't think having a fee necessarily discourages people from abusing the system or encourages people to use the system who need it. What you're talking about in terms of people needing to have a connection with their healthcare provider so that when they're experiencing difficulty, they feel comfortable going to that healthcare provider to talk about those services, I think is completely separate from the fee service. It has to do with how we approach healthcare.
So you and the Green Party would not support the idea of pay per service, even if it's a little bit of pay?
We don't support the idea of pay for service. We support having a more effective healthcare system that deals with the things that tend to create ill health.
Okay, let's move to the second topic, which is contracting out services, which is an equivalent of privatizing, which is in the same line of the 3 Ps. Where is the Green Party stand with the 3 Ps, private partnerships, private-public partnerships?
So the Green Party believes that the evidence would suggest that in the course of what we've done in the last 10 years, public-private partnerships have not saved the people of British Columbia a lot of money, with the exception of the hospital in Victoria, which came in under budget because of the P3.
You mean the
Jubilee Hospital, at a point in time where costs were escalating for construction, we got a good deal on that hospital. But most of them tend to cost more money because the private operator expects a return on their investment, which is higher than they would normally get if they were simply building the hospital for the government.
And that partnership includes operations, of management of the building and all that. And in the long run, you think that the private partnership is going to be better than if it was kept public?
Well, I think that we need to look at all kinds of ways that we might manage aspects of our healthcare system, including our hospitals. It's not always true that the government is a good manager. And the reasons that we've moved to things like the P3 model is because there was evidence within the bureaucracy that it wasn't a very efficient way of doing business at all times. So I do think we need to explore
You
options.
mean the government's managing wasn't as efficient as the private sector?
I'm not saying that. I'm saying that the government's management of the bureaucracy wasn't always efficient. And so the solution to that on the part of the BC Liberals was to go to a P3 model because they assume that the private sector can do it better. Mm-hmm. So given that there is evidence that the bureaucracy was not as efficient as it could have been, we need to look at what are better strategies for managing things. Doesn't necessarily mean that the automatic choice is privatized as a privatized model. If that makes any sense, we might explore things like a cooperative or a nonprofit. There's hospitals in the States, for instance, that are managed by a nonprofit organization that have very good results for their patients.
P3s are being used to privatize almost every piece of the public sphere: roads, prisons, schools, hospitals. There is no bit of the public sphere that isn't now being liquidated, privatized, and redefined as private property with private interests.
Since we launched the Public-Private Partnership Initiative in 2002, we've actually either started or completed $4.7 billion in new P3 projects.
It's very, very big. In the UK, the government has now signed £57 billion, or that's over 100 billion Canadian dollars in P3s. It's being rolled out right across Europe with more than 70 billion euros of P3s. And of course, as you know, it's going to India, to Africa, and Canada. It's sometimes called private finance or the Private Finance Initiative. So now what's happening is instead of government doing the borrowing directly, it's going indirectly to the private sector, and it's getting into 30-year or 50-year contracts, and it's being tied in. And of course, the private sector is much, much more expensive. The bank, on average, you're paying 2% more in banks, but you've also got the introduction of shareholders, so they also have to be paid. And the government's argument, though, of course, is that it doesn't matter that it's more expensive because the private sector is more efficient and it's taking on the risks. So therefore, it has to be rewarded. But don't you worry, the Canadian government is committed to debt busting. It's committed to low government borrowing. And so it is arguing that P3s will help because they'll take it all off the government balance sheet.
In fact, I can tell you today that we're going to be making that a condition of provincially funded capital projects as over $20 million in the future.
So that's the first one, is that the government says that it will enable fiscal prudence, lower government borrowing, and lower government expenditure. That is an absolute myth. But it's one that you will hear over and over again when you hear about debt busting and fiscal prudence. These are the management consultants and advisors to the government, which was saying for each P3 signed, you're going to see 1,000 job losses, about 25% of the workforce and the beds. So I think this is very important to remember. And some of these losses will be disguised. They won't be from the hospital, they'll be from the community and the primary health service. So that's the affordability issue. That's how the private sector is more efficient. It simply closes beds and closes hospitals. But in the process, these efficiency savings are known as externalities because you're externalizing the costs to the patients, the community, the carers, and the staff. But the private sector is efficient because it's externalizing those costs. So this is how the affordability problem is dealt with and the efficiency of P3s. Now, we have looked at all of the first wave, around 20 hospitals in England, the P3s. And this is being repeated for schools, for roads, for prisons. This is a huge public policy, which is totally discredited in the UK and very well understood by the ordinary person in the street now. What about the second test, value for money? Your Canadian government says it will not sign any deals unless they're value for money.
We know P3s save money, transfer risk, and add great value through design innovations and private sector ingenuity.
How many of you heard that term? And the reason why we're paying such a high premium to these bankers and shareholders is because they're taking on the risk. And so you want to reward them for that. Fair enough. So our government, a couple of years ago, said we've now signed more than 400 projects, So we've got a really good evidence base, so we're going to look at the value for money. We've got sufficient evidence to assess the early performance of the program. So what was the evidence that they provided? And the reason why I'm going to show you this evidence is it's because the evidence that the Canadian government and the BC government is quoting over and over again. The only bit of evidence they could provide around risk transfer was that projects were coming in on time and on budget. Well, I should hope so at the price that's being charged. And they use this figure that 70% of non-P3 projects, i.e. the public projects, were delivered late, and 73% were ran over budget. Now that's terribly important because that's used in all the modelling when you're comparing the public and the private sector. And it's also used by the federal and the provincial governments to justify the policy. They keep quoting these UK magic figures of 70%.
We're getting at least $131 million in additional benefits on the Sea to Sky Highway. At least $92 million in additional benefits in the new Canada Line. $39 million in additional benefits in the Abbotsford Hospital and Cancer Care Centre.
Nevertheless, we took it at face value and we thought, let's look at the evidence for the 70% running over time and budget in the public sector. We found that the government had 5 reports it kept quoting. 2 from the National Audit Office, which is like your Auditor General Office, 1 from the Treasury itself, and 2 from their favourite management consultants. Now, when we looked at the Treasury's own report, we put in a Freedom of Information request. And we kept putting in the Freedom of Information request. And then in the end, the Treasury had to put their hands up and say they didn't have any data. They hadn't actually done the research that they were citing. So then we went to the equivalent of the Auditor General, the National Audit Office. And we looked at their reports, but they were just interviews with managers who were doing the PFI, the P3 projects. So you couldn't say that all these public projects weren't coming in on time and on budget. And the National Audit Office in the end said, we put our hands up, we don't have the data. But we were using 2 management consultant reports. But when we looked at the management consultant reports, we also found that they had completely fabricated the figures. There were no meaningful data. Now, we've published these as academic studies, and you can find them. So the only bit of evidence that the UK government has that these schemes are value for money and they've transferred risk is the cost and time overrun data. But the figures that they're quoting are made up. And yet, your Canadian governments and the media keep rehearsing these figures. So the only value for money data is fraudulent. So what about the rewards? Well, one of the problems is that the contracts, when you ask for them, are deemed commercial and in confidence. So you put in your Freedom of Information requests, and when you get the contracts, they're about that deep. And when you look for all the really interesting stuff, like how much the shareholders are getting, it's all what's called redacted, deleted. So you don't get the data.